Hello and welcome everyone. It is another live event tonight, so thank you already for joining us tonight, and it's good to be back. I'm your host, Caroline, and I'm back here with Dr. Harry Karpouzis. Hello, Dr. Harry, how are you feeling tonight?
I'm very fine. I'm hope you are fine too, and I want to thank everybody for being here on a Friday night.
Exactly. Thank you so much indeed, because this is like you said, a Friday night. So, thank you for joining us, and I'm sure that you have some questions for Dr. Harry tonight as well. But of course, before he will answer your questions, we will start off with his presentation. And the topic for tonight is how can endometriosis affect the implantation rates in IVF? And before we start with this presentation, let me just remind everyone that, of course, all of those events have been brought to you because we do want to help you out with all of your questions. And also, we want to give you the opportunity to meet the top fertility experts from different countries. Tonight, we are connected to Greece. As you know, this is a Friday evening. That means that we have those Greek events, I would say, as we always invite Greek doctors, as we want to promote Greece as a fertility destination of 2021. And I just want to mention that Dr. Harry is a partner and ambassador of this whole initiative as well. So thank you so much, Dr. Harry, for supporting that one as well.
Yeah.
And of course, I also want to thank for all the ambassadors and partners that are supporting our Stronger Together initiative. As you know, it would be very hard to simply provide you with so many of those live events without their assistance as well. So huge thanks for that. And just let me mention that Dr. Harry is the founder and scientific director at IVF Pelargos Fertility Group. And of course, as I've mentioned, he will now start with his presentation. Afterwards, don't forget to type those questions in the chat section so that Dr. Harry can answer them for you right after his presentation. And I guess we can go ahead and start with the presentation, right, Dr. Harry?
Yes, yes.
Wonderful. Thank you so
So
much.
you're welcome. So we'll talk today about endometriosis. We have talked before about endometriosis, so I will try some of the slides that might be repeated to go a bit quicker, because it is a big presentation as well. First of all, endometriosis is the presence of endometrial tissue outside the cavity of the woman. It does affect the quality of life by causing mainly pain. It affects about 7 to 10% of the women in reproductive age and is present in 30% of the infertile women with pain. 25 to 50% of infertile women have endometriosis, and 30 to 50% of women with endometriosis are subfertile. So these are some numbers just to understand the significance of endometriosis in the field of infertility. The endometriotic lesions, when we put the camera inside and we're doing a laparoscopy, they have variable appearance. They can be red, they can be black, white, they can be in the ovaries, they can be elsewhere inside the cavity, superficial, causing nodules, which are deep endometriosis. They can even get yellow. And for example, those are some pictures from laparoscopies. All these pictures are endometriosis, and you see how different can be inside the tummy. There are a lot of theories about endometriosis. I don't think that we need to talk about all of them. What we need to keep is that endometriosis is a disease that we don't have a clear explanation, and this is why it is a very difficult condition to understand and to treat. The most significant theory actually is the one of the retrograde menstruation, which means that according to this theory, period at the time of the menstruation can go through the tubes inside the tummy, and it can be implanted over there. And according to this theory, there are a lot of mechanisms that these implantations and this fluid of endometriosis inside the abdominal cavity can stimulate the immune system, can cause natural killer cells can cause macrophages, which are cells that are recruited every time that we have implantation. Cytokines, interleukins, growth factors, all those are inflammation markers and can cause a toxic environment both for the endometrium and the ovary. The grading, we have 4 degrees of endometriosis, and we just divide it into minimal, mild, and moderate severe. Of course, we know about the symptoms. Most of us, it's severe pain in periods, in sex, chronic pelvic pain, chronic fatigue, even pain in defecation when it affects the bowel, and of course, subfertility. Infertility and endometriosis, why endometriosis can cause infertility? First of all, because of mechanical causes. It can cause adhesions that can affect the tubes, but in the ovaries, it can alter actually the tube to ovary relations, okay, which means that it's not that easy for the tube to be motile, and this can impair the oocyte, the egg, to be picked up by the tube. As we said before, all the situation inside the tummy can increase a lot of inflammation markers, and this can affect the sperm motility, the sperm to egg interaction, and the implantation, of course. And as we said before, we have also the autoimmune system to react, which can cause anti-endometrial antibodies according to some research, and even cell-mediated autoimmunity. And all these things may affect the implantation, as we will see later. There are hormonal factors as well, and we know that in endometriosis, we don't have a proper creation of the follicles. We may have a second cycle phase deficiency. We may have increased prolactin, and all those things can affect the fertilization and the implantation. What is for sure is that the monthly fecundity rates, I mean, this is the percentage of the people that get pregnant in 1 month, the chances actually of getting pregnant in 1 month, I'm sorry, are lower in women with endometriosis. Few things about how it affects the ovarian function. It can affect ovulation. As we said before, it can cause structural alteration in the ovary and the tubes. And because of that, we can have a reduce of the ovarian reserve. Also, endometriosis causes the chocolate cysts, endometriomas, which can mechanically damage the ovarian tissue and also affect the blood flow there. Endometriosis is inflammation, and all this inflammation can also affect the ovarian tissue and can cause a toxic environment. And the endometriomas, the chocolate cysts, have got toxic substances inside too. What is for sure is that the ovarian reserve is affected, and we have research about that. We know, for example, from one study that the androgen follicular count in women that didn't have the endometriomas, the chocolate cysts operated, it is in this ovary, it is lower than in other ovaries that they are healthy. So when there is endometrioma and when there is disease over there, we have a smaller androgen follicular count. And also, other research proves that the AMH when we have endometriomas is lower. And also, there is other research that shows that when we have significant disease, grade 3 and 4, the AMH levels are lower. And according to this research, there is not a big difference in mild disease. So there is a lot of conflicting evidence actually with all the research regarding endometriosis, but most of it agrees that it can reduce the ovarian reserve. Implantation, and the implantation of the embryo can depend on the egg, and the quality of the egg and the embryo can depend on the endometrial receptivity, so on the endometrium and the environment there, or their altered interaction between the embryo and the endometrium. Again, there is a lot of research. I don't think that we need to stand in all of this research, but for example, one research over here by Pellicer shows that he did what? He actually created a model where we had embryo transfers in egg donation, and donors and recipients were without endometriosis. And then we had donors that had endometriosis and recipients that didn't. And then we had donors without endometriosis and recipients with endometriosis. And there is the data actually from this research showed that when we had donors with endometriosis, the pregnancy rate was only 6.8%. In the other two occasions, it was almost similar. So from this research, for example, we find out that most probably the reduced chances of success in patients with endometriosis and IVF are mainly because of the oocyte quality, mainly because of the egg quality, and not so much because of the endometrium, which plays a role too, but the main factor most probably it is the egg. Recurrent miscarriages and endometriosis, which is also failed implantation, does it cause miscarriages? A lot of data again and a lot of research behind it. Some conflicting evidence. Some of them show that yes, it can increase the chances of miscarriage in the first trimester. Some of them show that maybe it doesn't affect so much. A lot of studies that have to do with autoimmunity, which according to the studies, it is increase of antibodies that can attack the implantation, it is increase of natural killer cells and auto antibodies against the endometrium. And all those things may affect the implantation in the endometrium. Let's go to the next slide. So what is the treatment and the diagnosis? The golden standard of diagnosis is laparoscopy, and only with laparoscopy we can make a diagnosis. Also, at the same time, we can treat, and we know, and we have got evidence for that, that surgical treatment of endometriosis improves the spontaneous conception rates when we have a mild disease. With severe disease, and regarding the spontaneous conception rates, it is conflicting evidence. And also very important is the experience of the laparoscopic surgeon in endometriosis, because it is difficult surgery. And we need, for example, when we have a chocolate cyst, it is very important the surgery to be done correctly with a slow technique, with no blood loss, so that we don't need to burn all the time the ovary, with proper removal of the cyst, and all these are very important. And when to make a decision to operate on endometriosis is also very important, because it depends on the ovarian reserve and what you do actually with endometriosis. There are many options. When the ovarian reserve is low and the patient is old, most probably the solution is IVF, or if the tubes are affected. When someone is young and when has a good ovarian reserve, then it depends. You can go ahead with surgical treatment, you can try IUI, or if this doesn't work, you can again go to IVF. So we said again that the treatment actually with endometriosis in the mild disease, the laparoscopic treatment increases the spontaneous conception rates, and we can see that in those two researches. And also regarding IVF and surgery, do we need to operate before IVF? Again, the answer is not clear. There is some data and some research that shows that if we remove all the mild endometriosis before an IVF, this can increase the IVF or ICSI chances. On the other hand, what we know for sure is that the surgery itself in the ovaries can reduce the ovarian reserve. And we know, for example, that when we have unilateral cystectomy, the AMH levels can drop because of the surgery. Also, we know that maybe the AMH levels can be decreased up to 38% in some other studies. We have evidence from other research that compared non-surgery with surgery before IVF, that there is actually no difference. Not only that, that sometimes after we remove a cyst and then we go to IVF, it's getting more difficult to stimulate the ovaries because the ovarian reserve has dropped more. So actually, the most recent data says that if we have an endometrioma, even if it is less or sometimes even more than 3 centimeters, we may need to make a very careful decision on if we need to operate on it or not. And sometimes the answer is no surgery. Always check the AMH before and after, and it is a very good way to see how the surgery has affected the AMH as well. And also the AMH gives you the answer on if you need to operate or not. Of course, generally after surgery, including spontaneous conception and IVF, there is increase in the pregnancy rates. We've got the NICE guidelines and the ESRE guidelines, which actually says that if we do a laparoscopy, diagnostic is not okay, we need to treat, and this can increase the spontaneous conception. If we have mild disease, we need to treat because this increases the pregnancy rates. Regarding the mild disease and the surgery before IVF, the evidence is not clear, but according to some evidence, if you treat, you may improve the pregnancy rates, but we will see that a bit later. Next slide. It's a new test. It's BCLX test, 6 test. What is this? It's a protein actually, which is produced by a gene, BCL6 gene. And actually, what is happening with that? It is found that, I mean, we can test about this protein with a biopsy. When we have elevated expression of the BCL6, we know that there are lower pregnancy rates and live birth rates. And this test is increased in 75% of the unexplained infertility women. And this shows us that BCL6 is a protein that is identified when we have inflammation. And inflammation usually is caused by endometriosis. So most of the time, BCL6 is a way of identifying endometriosis if we don't do a laparoscopy. And also this shows that many unexplained infertility cases, in reality, they are due to endometriosis. We just don't know it. And why is it important, this test? We will start putting it into our practice soon. It's important because we have evidence that if someone is found that has increased BCL6, which means possible endometriosis, needs treatment. And it's data that if we treat either with a laparoscopy or with GnRH injections and medical treatment, this increases the chances of implantation at the time of the IVF. IUI is an option. The chances are not more than 15% with IUI general, and sometimes in endometriosis they may be even lower. Also, if we do IUI or not, it depends on the AMH, of course the sperm, if we have patent tubes and other things. The truth is that if we are talking about after surgery and the young person that has mild disease, we can try with IUI, and the most important period to try is about 6 months after having a previous surgery. So we can give it a bit of time to try spontaneously, and if it doesn't work, then we can give up to 3 cycles of IUI. But the patient needs to know that the chances of success with IUI are much lower than IVF, and usually it is not the indicative treatment and the most good treatment. But in some cases that are very straightforward, it can increase the chances in comparison to spontaneous conception. Okay, protocols in IVF, do they play a role? What's the best protocol? The old data said that when we do a long protocol, we get a bit of higher amount of eggs and more embryos available to freeze, and possibly a cumulative fecundity rate would be higher. But it's not actually this way. We know that, first of all, long protocols are less convenient, more prolonged, more injections, and also when we have poor ovarian reserve, they downregulate the ovaries a lot, and sometimes it can have the opposite result. One other option, if we want to keep the disease silent, is the pill, a pre-treatment of the pill. We just need to make sure again that we start the injections about 6 days after the stop of the pill so that they can recover. Actually, most of the cases nowadays, we prefer even not to do anything before if we have a mild disease. Stimulate the ovaries, get the eggs, and then it is very important to down-regulate the disease before a frozen cycle. We'll talk about that later. I don't think that there is any reason of going through that. I mean, about endometriomas, according to the data, 17 to 44% of the patients with endometriosis have endometriomas, and we can see in this table over there that there is a difference in the success rates of IVF. It's much lower when we have endometriomas rather than when we not. Again, the guidelines from ESRE, when in infertile women with ovarian endometrioma undergoing surgery, we need to remove the whole cyst and not only burn. Okay. The second thing is that when we have an endometrioma, the patient needs to know that the surgery may reduce the AMH, and this is something that we need to talk with the patient so that they know it. Sometimes it's inevitable. It depends on the correct surgical technique. It depends on the surgeon, but sometimes it is inevitable. So do the AMH before and after. It's very important and make the right decision. Now, it is a bit slow. Again, what we are doing when we have endometriomas more than 3. As I said before, the most recent data actually says that when we have a big endometrioma, trying to remove it drops a lot the ovarian reserve. So it depends on many things, but it's not necessary. And there is no data that says that really improves the pregnancy rates. So when do we need to remove it? We need to remove it when we have pain, of course, which is a priority, or when we need to access the follicles, and this is difficult because of a big cyst. The disadvantages of surgery, we've talked about decreased umbilical follicular count, decreased AMH, and decreased response to controlled ovarian stimulation. Lots of data proving that. Some more data, for example, which says that as big as it is the endometrioma, the more chances of causing ovarian damage. And also in the table, in the second table, we can see that when we have surgery, the number, the stimulation may last longer, and we may need a higher dose of injections and get lower egg numbers, but actually in the end, we may not have difference in the pregnancy rates. Advantages and disadvantages of surgery. We need, as we said again, to make sure that we take care to the ovarian reserve, and we know a surgery can drop it. It depends a lot on the surgeries, on the surgeon's abilities and capacities and experience. Of course, if we leave the disease there, this can cause inflammation that can affect the egg, can make more doses of GnRH analogs to be needed before the stimulation or before the embryo transfer. So there are many advantages and disadvantages regarding if we need to operate or not. And the answer is actually, so that we don't confuse you, that it needs to be personalized. It depends on the medical test, it depends on the age, it depends on if we have past surgery or not, it depends on many things if we need to operate or not. For example, in the repeat surgery, there is a clear evidence that we need to avoid it. Unless we have severe pain that affects the quality of the life, second surgery in the ovaries, it's better to be avoided when fertility is an issue. What about the quality of the eggs? Again, there are many studies that show that endometriosis may affect the quality, and there are some studies that say that they don't affect the quality. The certain is that the number of the oocytes retrieved is reduced. The embryo quality, according to some data, can also be reduced because of the toxic environment that the disease causes. We can see here, for example, the egg sometime in the endometriosis. When we retrieve it and we look at it in the microscope, it looks sometimes dark, it looks fragmented, it looks with changed spindle morphology, with dark central granulation. We can see eggs like that when we retrieve them in the microscope, and they are caused from endometriosis. The general thing that you need to remember is that endometriosis is inflammation, actually, and this can cause dysregulation of the immune system, as we said, can cause natural killer cells, cytokines, growth factors, and all these chains can affect both the quality of the oocytes and, as we said before, the endometrial implantation too. Again, we see that, for example, in some research, the embryo development in women with endometriosis is slowed when we compare it to women that have, for example, a tubal disease. We talked about the study that showed that when we receive eggs from donors that had endometriosis, we had dropped success rates, and we have a lot of substances that can cause a toxic environment to the egg and the endometrium. About GnRH analogs, about all those injections that people with endometriosis most probably know. Do we need to give them? ESHRE says that they don't change the fertility when we are looking for natural conception, but when we have planned for an IVF, then yes, they can improve clinical pregnancy rates. But I will say here that this is not guaranteed. What is the common practice and what we do nowadays is we definitely use the GnRH analogs before a frozen cycle, but sometimes if the AMH is low, we don't use them before the stimulation of the ovaries, because this can affect the amount of eggs that we can get. So sometimes it's better to use the pill or nothing, stimulate the ovaries, get the eggs, and then freeze and downregulate with the GnRH and transfer on a frozen cycle. One other option is the pill, as we said before, and according to a review here by Ziegler, it can improve the outcomes with several ways. Let's go to the conclusions about the most basic things that we need to keep from this presentation. First of all, implantation failures in endometriosis looks like that they are mainly due to the egg, and the embryo development rather than the endometrium. On the other hand, immunological factors and toxic environment in the endometrium can also affect the implantation. There is not conclusive evidence behind that, but there is strong data that shows that it can cause immune alteration. The endometriosis itself as a disease, but the surgery to treat the endometriosis in the ovaries can both reduce the ovarian reserve. The medical treatments do not improve the natural chances of conception. The downreg treatment with GnRH analogs is adjuvant to IVF, can be given complementary to the IVF. But many times, as I said before, when the ovarian reserve is low, it's better to freeze and use the treatment before a frozen cycle. IUI has a role in some very carefully selected cases, but the IVF always gives better chances of success. And if we carry on, some other things that are very important in endometriosis. In order to properly treat, we need in medicine to completely understand, and this is not for granted in endometriosis. It's a disease that we do not completely understand. It is very important, though, to have a reproductive medical team and a surgical team with experience in endometriosis, because sometimes wrong decisions can cause things happen which are worse rather than before. And the wrong surgical technique or the wrong decision on operating or not can cause harm and make things worse. Protocols are to be followed, but sometimes in endometriosis you need to think out of the box and you need to take it always personalized. Every case is different, not only in endometriosis, but especially in endometriosis. And you need to think well before you decide what's the best protocol. Making the correct decisions in the management is paramount. The general thing is that IVF, there are the other treatments, but IVF will give you the quickest way and the most and the more chances of getting pregnant. That's it.
Thorough with all as well.
Caroline, I cannot hear you well.
Okay, please let me know if you can hear me now.
Yeah, it's better. Yeah.
Not sure what happened, but I'm right here, of course. So thanks a lot for this presentation and explaining everything to us. And of course, it is time to start with the questions. Some questions ready. And if you didn't ask your question yet, just go ahead and type this in so that Dr. Harry can help you out. And let's go ahead with the very first question that we have received. So, IVF doctors who say that IVF bypasses endometriosis issues are not acting with the best information.
No, IVF obviously bypasses a lot of endometriosis issues. For example, if the tubes are blocked, then the only solution is IVF. If the AMH is very low, then all other treatments have much lower chances of success. If there is a lot of toxic environment inside the tummy, with the correct protocol and fertilization outside the body, we can increase the chances of creating a good embryo. So definitely IVF, as I said in the presentation, is the best treatment. But as we know, IVF is not guaranteed in any patient. I mean, even in women 30 years old, IVF has got a ceiling of success rates, and we don't know why it doesn't work in some cases. Endometriosis is a very weird disease. There are a lot of things that we don't know about, and generally the success rates in endometriosis patients are lower without really knowing why it is lower even with IVF. But IVF definitely is the best treatment and definitely bypasses a lot of issues. So no, they are not wrong.
All right. Okay. Understood perfectly. Thank you so much for this. And actually, Claire has added, it's in regards to your presentation, yeah, the BCL6 biopsy tomorrow. So best of luck, Claire, for sure, as well. Thank you so much. Okay, and let's have a look at the next question, which is a bit of a longer. I am 34 with 1.1 pmol AMH, surgery done during diagnosis and only adhesions cut, and though not removed, doctor thinks it will cause more harm. I also have endometriomas on my left ovary, 2 centimeters. It wasn't there, was diagnosed last year. What can I do to improve my chance of successful IVF? And I am due my first round soon.
Well, you need to go ahead with IVF because I don't know how long you've been trying, especially if you've been trying for more than 1 year or more than that. The answer is IVF. I wouldn't operate to you either with that low AMH. I would start with a protocol with the right dose and the right protocol and stimulate your ovaries. And because you do have disease inside your tummy and you do have active disease, to our clinic, to our protocols, we would prefer most probably if we get embryos and we have some good embryos, freeze them, down-regulate the disease with GnRH injections, and then transfer on a frozen cycle. But of course, every clinic has got its own policies and its own protocols. So, yeah.
All right. One understood once more. Thank you so much for your question and of course for your advice on that as well. And let's have a look, okay? And the next question from Angela. In your presentation, it stated that free iron can affect the quality of oocytes. What does that mean? I suffered from severe endometriosis my entire life and also anemia and was told to take iron supplements. Could this have caused my miscarriages or lack of ability to get pregnant, even with many IVFs?
No, I think you didn't. It was not clear, most probably, because I was trying to explain the ways that endometriosis affects the ovaries. And one of the ways is that endometriosis is actually deposits of blood inside the tummy. So blood has got iron inside, hemoglobin has got iron. So we have a lot of iron inside the tummy because of the disease. And this iron can be toxic to the ovaries. This is a theory to show how it can affect the ovaries. So it's not the anemia related. It doesn't have anything to do with that. Now about the miscarriages and the inability to get pregnant, well, it depends on many things. It can depend to the disease itself. It can depend to the quality of your eggs, to your age, other factors. There are a lot of investigations that you most probably have already done about investigations of miscarriages, and usually IVF is the best solution on that. It depends on your medical case.
And excellent. Thank you so much once more for that explanation to this question. And let's have a look at the next one from Claire. What is an example of GnRH medications?
Uh, Generates analog medication. There are injections that are given either one-off to down-regulate the ovaries, like gonapectyl and injections like that, or they can be given daily for 14 days in a smaller dose to do the same job. So actually generates a medical treatment of endometriosis, but not only endometriosis, it actually suppresses the ovaries so that we can and the disease at the same time, which depends, as we know, in hormones. It shuts down the hormones so that we can deactivate the disease and transfer embryos or stimulate the ovaries.
And excellent. Thank you so much for yet another question, of course, and for your answer to this one as well. And there is a follow-up. Okay, can you say more about down-regulation protocols?
There are not a lot of things. You mean stimulation protocols, most probably, to stimulate the ovaries, because I mean there's the long protocol that we give for many days injections, which are different. It's GnRH agonist. It's the short protocol that we give for less time injections, and we use a different sort of medication to prevent the ovulation, which is the antagonist. every protocol depends on its independent situation, on the age, on the AMH. In our clinic, we usually prefer to use the antagonist protocol, which is more convenient for the patient as well, because we think that we get more eggs, and we prefer to freeze and transfer on the frozen cycle after we down-regulate the ovaries, and we down-regulate the ovaries with the injections that I just mentioned before, or the pill, the combined pill.
All right. Sorry, Claire has added something. Okay, so let me just go straight to
Yeah.
that one. So I did mean for suppression prior to frozen embryo transfer,
Oh.
not stimulation. My doctor doesn't have experience with this.
Well, in a frozen embryo transfer, you can start, you can do it with three ways. The first way would be in a natural cycle. The second way would be on an estrogen replacement, which means that you get estrogen to increase the thickness of your endometrium, and then you start the progesterone. And there is a third way, which is to suppress the ovaries, and you suppress the ovaries by the GnRH analog injections, which are given either on day 21 or day 1 of the cycle. And after that, you start the estrogen replacement. In endometriosis, usually we prefer to do that, especially if we know or we suspect that there is active disease inside the tummy.
And actually, there is a comment from the patient. Got it. Thank you. So thanks for that, of course. And let's have a look at the next question that we have from Melissa this time. Are there things that we can do to give us better chances of falling pregnant naturally or with IVF with diagnosed by endometriosis?
Uh, well, keeping a healthy lifestyle, taking some multivitamins, some antioxidants. Sometimes there are a lot of multivitamins in the market. Uh, Avoiding, like everybody, smoking and drinking alcohol. Having food with a lot of fruits and a lot of antioxidants are things that can help you with endometriosis, actually can help the IVF or the medical treatment to have better results.
All right. Again, thank you for that. And there is another question from Melissa. Let me go straight to that one. So, does surgical removal of endometriosis only affect AMH when it involves removal of endolesions from the ovaries? I have had one lab 10 years ago with endo excised from my bladder, pouch of Douglas, and bowel. After having my eggs frozen for fertility preservation, my endo pains have come back worse, and a gynecologist suggesting another laparoscopy, but I already have very low AMH.
Yeah, when you don't have surgery in the ovaries and you have surgery in other parts of the tummy, usually this surgery does not affect the AMH. The disease itself, though, even without surgery, can affect the AMH. And as I said in the presentation, we have seen that women with endometriosis, even with endometriomas, or even without endometriomas, which means even with cysts or even without cysts, have been shown to have less AMH. And actually, there is data that shows that it's not only that the AMH is lower, it's that it is declining in a more steep way. So your low AMH can depend on the disease itself, or can be completely irrelevant. It's not because of a surgery that doesn't have to do anything with the ovaries. If you are in pain, pain is a priority. If you need to make the quality of your life better, then surgery is needed. If it is a matter of fertility, then it needs to be a very well balanced decision. But given of the fact that you have some eggs stored and frozen, this is a good investment.
And again, thank you so much for that. And at least for now, there are like two questions left. So let's get to the next one. Is there a gold standard for hormonal management of endometriosis?
No. I mean, if you mean in IVF, I suppose, and fertility, because I mean, if it is a matter of pain or if it is a matter of symptoms, then contraception pills can help, and there is data that shows that there are things that can help. But if we are talking about fertility, there is not a golden standard of what we need to do, of what protocol we need to use. That's what I have explained in the presentation. There are many different things that we can do, and what we need to do in each case depends on the case. It depends, it's a personalized decision. It depends on many things, on the ovarian reserve, on the grade of the disease, on the age of the woman, of the tubes, if they are patent or not, on many things.
All right. Again, thank you so much for that. And there is a thank you. Thanks so much from Melissa. And at least for now, it seems that that might be our last question. But of course, if you have any left, just go ahead and type those in right now. And the question is, I guess, the age limit at the clinic, I guess, as well.
Well, the upper age limit to have IVF in Greece is 50 years old. We cannot do egg donation or IVF, of course, after 50. But if we are talking about IVF with own eggs, legally it can happen up to 50. But to be honest with you, after 45 years old, the chances are very low.
And wonderful. Thank you for the clarification to this one. And someone is typing, so I guess we will have another question. And yes, here it is. So let's have a look at the question. Next month, I am planning frozen embryo transfer inseminated cycle with estrogen stimulation right before ovulation. How many days before ovulation I need to use estrogen? What dose?
Well, your doctors will explain that to you. First of all, when you have a frozen embryo transfer, there is no ovulation. The whole point is not to have ovulation. So, if you are having a cycle with estrogen, usually you take the estrogen for between 12 or 18 days, depending on if the lining of your womb will increase in size nicely or not. And then you need to start the progesterone, and depending on what embryos you have, day 3 or day 5, 3 or 5 days later, you have the embryo transfer.
All right. Sorry, there is a comment. So I have regular ovulations.
You
Anything
have,
else?
but if you have frozen embryos, as you said, and there are embryos, the whole point in transferring an embryo is to stimulate your ovaries, to prepare your ovaries with estrogen so that you can increase the lining of your womb, and you don't want an ovulation at the time of the frozen embryo. So the pills that you take stop the ovulation.
Okay, thank you for that then. Okay, and I guess we can go ahead with the next question. So, what was the advanced age where a patient had a baby with own eggs at your clinic?
Well, it was 47, but it doesn't happen often. It happens one uh, every year. To be honest with you, the chances with own eggs in the age of 47 are very, very low. And in the age of 45 and more, the chances of success are very low with IVF with own eggs. But depending on the case and depending on the levels and everything, someone can try it as far as is aware of the real chances. So I try always to be honest with my patients and give the real chances, and then the decision depends on them.
All right. Okay. Thank you so much for that. This is definitely something that we receive. This is a question that we do receive quite often, of course. So thank you for that question indeed, as well as your answer, Dr. Harry. And let's have a look at the next question that we have here. So, will it be a problem when it comes to embryo transfer if I can't have estrogen due to being in higher risk of category of stroke?
Well, there are other ways of doing it. You can do it in a natural cycle or with letrozole, which is a special medication that keeps estrogen low. So there are other options. If you cannot take any estrogen and there is a specific reason for that, then yes, you can do it with other ways.
Okay, wonderful. Thank you so much for once again for the question and for your answer. And next question is: so can repeated IVF cycles worsen the endometriosis or cyst in breast? Can endo and fibroids cause recurring miscarriage?
Well, there is some data which is non-conclusive that relates endometriosis with miscarriages, yes. About fibroids, depending on their position, yes. Also, they can cause miscarriage, but not all the fibroids. If we have a fibroid that it is outside the cavity, then no, usually it doesn't cause miscarriage. Depending repeated IVF cycles, if they can increase and worsen the endometriosis, the answer is that yes, it can happen. If there is active disease at the time of the stimulation, sometimes we see that the disease may flare up. But of course, if you get pregnant, then the disease is getting much better. The same with cysts in the breasts. Sometimes increase of estrogen can increase them, but imagine that in a pregnancy the estrogens go up many more times up, so this can happen in a pregnancy too.
All right, thank you very much, of course, and as you can see, there is a thank you from the patient for you. And next question is: so what is recommended endometrium thickness in native cycle or for frozen embryo transfer in time of ovulation?
Well, it needs to be more than 8, ideally more than 9, sometimes more than 7. Less than 7 is not good.
All right. All right. Thank you so much for that quick answer to this one, of course, as well. And I'm just waiting because at least at the moment we do not see any questions. However, if you have any left, this will be like the final call for your questions. So go ahead and type those in. If not, we will be finishing for tonight. But of course, remember, if you have any follow-up questions or you would like to get some more details, you can always get in touch with Dr. Harry, and I'm more than sure that he'd be more than happy to help you out, and of course just simply provide you with some more details. You can also always use the link I have just sent to you. And let's give it a minute because someone is typing. I'm not sure whether it's a question or a comment, so let's give it a minute to see. I guess this will be a question as it's someone is typing. It takes a little bit longer than usual, so I guess that will be a question. So let's give it a second. Still need to wait. Yes, and here is this. Of course, let's have a look at the question. So, what can we do to achieve optimal endometrium thickness in natural cycle, I guess?
Well, you don't usually, if the endometrium doesn't have a problem and there is no adhesion, scar tissue, past surgery in the endometrium, infection, or anything like that. Usually, in a natural cycle, when you do the embryo transfer, when you have a follicle which is the right size, you do have an endometrium which is more than 7. So you need just to, in a natural cycle, of keeping an eye on the follicle and knowing when you give the trigger injection and when you have the embryo transfer. So the correct timing of the whole procedure in a natural cycle is very important because sometimes the correct timing can be missed. Now, if there is a problem in the endometrium and it is not getting thick enough, then usually you cancel the cycle and next time you try with pills, with estrogen pills. Yeah, or you can try with another medication which is called letrozole if you don't or if you cannot take estrogen. So there are options.
All right, again, thank you so much for well, your question, and of course for your answer. And there are some, sorry, so I'm not sure. Yeah, there is a question. Sorry, let me just show you. Thank you for the presentation. What are the chances that a patient has PCOS, I guess, in IVF treatment? I'm not sure here. Sorry.
Yeah,
If you could
I'm not sure what is the question.
clarify what you mean, okay? What are the chances that a patient has PCOS, perhaps,
Uh,
but not sure? Yes, PCOS. That's right.
what are the chances that the patient has PCOS? Uh,
In IVF treatment, so with patient with PCOS.
well, if someone has PCOS, then and we reach the stage that we need IVF, then there are special protocols that we can use to stimulate patients with PCOS so that we minimize the risk of hyperstimulation and we get as many eggs as possible. So it's a different thing. There are a lot of people that are having PCOS, and some of them, if they don't succeed in a pregnancy with other ways, uh, they reach the stage of IVF, and then we have special protocols for them.
Okay, sorry. Thank you, Harry, for that. Patient has added that. Okay, yeah, that's that was, I guess, enough. Yeah, the patient with PCOS has
Well,
chances of pregnancy.
definitely, and usually patients with PCOS have got a lot of eggs as well. So usually the amount of eggs that we get is big. It's a completely different issue. PCOS, a very big issue. Maybe we will talk about it another time in detail.
Of course. We also had actually a webinar on that with you, I remember. So of course, remember that with the link I have sent, you are always able to simply go ahead to the link and just find some other webinars. Even with Dr. Harry there are like few already with Dr. Harry. So I can only encourage you to have a look at it, and I'm sure it's going to be helpful for you as well. And well, we will be funny. Sorry, before I say this, we have another question, so I guess we can still go ahead with it. So what are the chances to have a normal blastocyst at 40, having 4 blastocysts for example, yeah?
It can be good. First of all, it is very good that you have four blastocysts, which means that you have reacted very well. I mean, we have chances of success of about, I mean, 45%, even more sometimes in 40s with special protocols. So for a positive pregnancy at least test. So you have good chances of one of them at least to be healthy, and you don't need any more. You need one to get a baby.
All right, that sounds good then. Thank you so much for this. And I guess we will be finishing for today. And there are some thank yous coming up your way, Dr. Harry, as always, right here as well. And there was a thank you from the patient, and of course, some more of those right here. So thank you so much, everyone, for your questions. Indeed, I do believe that it's been useful and helpful, and of course interesting for you, Dr. Harry. It's always a pleasure. You know that, so we always are happy to have you back on board with us and having some more webinars with you. I know it's just a matter of time till our next event. So as always, thank you so much. And is there
Thank
anything
you.
else you would like to add before we go?
Nothing. I would like to thank you and everybody for attending, and wish to everybody a nice weekend.
Excellent. Thank you so much. And of course, remember, it has been recorded. So again, you will be able to see it on myivfenses.com or YouTube channel. And as you know, we will be back on Monday with another interesting session, I'm sure. And there are plenty more of those events coming up. So I do hope you will be able to join us. That's on Monday. But of course, now let's focus on the weekend. So everyone have a wonderful weekend, relaxing one. Dr. Harry, it's always great to have you back. So thank you a lot.
Thank
Also, have a
you.
very nice weekend until our next event. Take care, everyone. Good
Bye.
night. Bye.